So today we are going to talk about the classification, and discuss the etiology, pathology, clinical features, the differential diagnosis of cervical cancer, what all investigations we need to do before we can manage, the staging, both the new and the old staging, and the management of cervical cancers. We need to know the facts and figures first. Worldwide, cervical cancer is the fourth most common cancer among women, but in India it is second most common after breast cancer. Breast cancer happens to be the most common cancer, followed by colorectal and lung cancers. Cervical cancer is fourth. Worldwide, there is around 5,70,000 new cases and 3,10,000 deaths in the year 2018. You will remember from last week's slides that cervical cancer in India contributes 1 in 4, that is around 25% of cervical cancer burden, both in terms of new cases as well as in terms of number of deaths. In India, every year we find 1,30,000 to 1,40,000 women newly diagnosed with cervical cancer, and 70,000 of these women die. This is for a cancer which has got a huge latent period of 10 years. It has got good screening, as we have noted in the previous class, and there is a vaccine also. So it's an unfortunate situation, a matter of really shame that this is a condition. What are the risk factors? Young age at first intercourse, younger than 16 years, multiple sexual partners, cigarette smoking, race, hair parity, low socioeconomic status, and chronic immunosuppression. Cervical cancer often tends to happen in women with HIV or those with renal transplants, those with uncontrolled diabetes who have low immunity. It is bimodal in nature. Mean age is 47 years. The first peak of cervical cancer happens between the age of 35 to 39, and the second peak is between the age of 60 to 64 years. Because it coexists with HIV, it is often known as a AIDS-defining illness. As we have noted in the previous class, the initiating event is dysplasia caused by human papilloma virus. Type 16 and 18 contribute to 70% of cervical cancers. CIN2 and 3 are the true precursors. And the mechanism is through interaction via the E6 and E7 genes, which downregulate the tumor suppressor genes P53 and retinoblastoma. So first, coming to diagnosis, what are the symptoms we will be looking out for? These slides have been borrowed from Berek and Hackers, which is one of the sacred books of gynae-oncology. So you will do well to concentrate on these slides in here. Abnormal uterine bleeding, okay, postcoital bleeding. Postcoital bleeding is the most specific symptom of cervical cancer. Postmenopausal bleeding is another symptom. Postmenopausal bleeding, the most common cause is uterine atrophy or endometrial atrophy. Around 10% is due to cancers, of which mostly it is because of cervical or uterine cancers. Sometimes there is a malodorous vaginal discharge which is seen before the bleeding actually starts. And when the cancer is advanced, patients will also have pelvic pain. They will have pressure symptoms due to the bowel and the bladder. And when it's involving the pelvic sidewall, the patients may go on to have leg pain. They may go on to have a sort of a radiating, tingling sort of pain down the thighs. Signs. See, when you are examining the cervix, you remember from last class we use a Cusco speculum. When the cervix appears unhealthy, it looks like a mass with ulceration or proliferation or with infiltration. Okay, then we have to see how big that lesion is. We have to see for signs of fixity, friability. It breaks easily on touch. It bleeds easily. Products of conception in incomplete abortion. Sometimes the products do not come out on their complete. A part of it comes out and the remaining stays behind. It looks really florid, like a cancerous growth. And or a fibroid polyp. Fibroids, particularly, you may have at a class submucosal polyps. with a pedicle. It may be looking very dirty looking or a shaggy appearance, which is when it can mimic a cervical cancer. Gross pathology. The lesions can be exophytic like a cauliflower, ulcerative, or it can be infiltrative. Infiltrative growths are sometimes difficult to diagnose because cervical growths tend to be more proliferating type. Pathology, you need to remember this. You might be asked, what is the commonest type of cervical cancer? So it's squamous cell cancer. 80% of cervical cancer is squamous cell cancer. In squamous cell cancer also there are subdivisions. The commonest type is non-keratinizing type of large cell squamous cell cancer. So there is squamous cell cancer, there is large, in squamous cell there is large cell SCC and small cell SCC. In large cell there is keratinizing and non-keratinizing. Non-keratinizing large cell SCC is the commonest type. Small cell cancers tend to be very aggressive, they like carcinoid tumors and spread. 20 to 25% of cervical cancers are adenocarcinoma. In adenocarcinoma, HPV 18 is more important than HPV 16 in terms of causative agent. Okay, and cigarette smoking plays a more important role. The majority of adenocarcinomas are endocervical type, though you may find endometrioid clear cell adenosquamous. Adenoma malignum or minimal deviation adenocarcinoma is a subtype of adenocarcinoma, but it has got a good prognosis. Then there are neuroendocrine tumors. How does the cervical cancer spread? It can spread direct contiguous spread from the cervix till the body of the uterus. Okay, it can go below to the vulva and the vagina. So patterns of, or it can be spreading by lymphatic permeation. So often you might be asked in the exams, what is the stage of the cervical cancer? If the cervical stage is 1B, what percentage of lymph nodes might be involved? So what are the first lymph nodes which are involved? Are immediately adjacent to the cervix and to the uterus, the parametrial and the paracervical nodes. Then the cancer spreads to the obturator node. Obturator node is often known as the first lymph node to go and get involved. That is known as the sentinel lymph node. Nowadays, when we do cervical cancer surgery, particularly in early stages, stage 1, stage 2A, earlier what we used to do is that we used to remove all the pelvic lymph nodes. Even now that is the standard of care, but latest advance, what it's saying is that if we remove all the lymph nodes, it can result in lymphedema or collection of lymph within the abdomen known as lymphocyst. To avoid these eventualities, we use a technique known as sentinel lymph node, where we inject radioactive tracers like technetium-99, or more commonly nowadays we use indocyanine green ICG, and we make use of a gamma camera to see which lymph node is involved. It tends to look like a bright bottle green appearance, and that is the sentinel lymph node. We take the sentinel lymph node out, we send it in the lab immediately for a frozen section. If the sentinel lymph node comes back as positive, that means the cancer is already stage 3. In that case, there is no point of operating any further or removing any further lymph nodes. Whereas if the sentinel lymph node comes back as negative and it is properly mapped, then we need not remove all the remaining lymph nodes. Because if the first lymph node is not involved, then the other lymph nodes will also not be involved. And by not removing all the lymph nodes, we tend to avoid lymphedema and lymphocyst. So the pattern of lymph node spread is very important. First paracervical and parametrial nodes, then external, then obturator, internal iliac, external iliac lymph nodes, then the common iliac lymph nodes, then the pre and the para-aortic lymph nodes. Or it can be hematerogenous spread. Hematerogenous spread is when it spreads to the distal organs like the lung, the liver, or the bone. If it is spread to these organs, then it becomes stage 4 disease. So this is a very important chart. Stage 1A, I will talk about the stages, is when stage 1A means you cannot see the cancers. It is micro-invasive cancer. Alright. So you are able to just see some changes on colposcopy, and then you are assured that it is cancer only after the biopsy. For stage 1A, the lymph node involvement is almost 0. For pelvic, it's 0.5%, para-aortic, no lymph nodes are involved. Stage 1A2, 1A1 is when it's 3 to 5 millimeters in depth of invasion. Stage 1A2 means the depth of invasion is stage 1A1 is less than 3 millimeters, 3 to 5 millimeters. So I will come to the staging here. 1A1 is when the infiltration is less than equal to 3 millimeter in depth. 1A2 is 3 to 5 millimeters. So 1A2 onwards, the pelvic nodes are involved around 5%, but para-aortic is less than 1. With 1B, it's 15% and 2%. 2A, it's 25% and 10%. 2B is 30 and 20. 3 is 45, 30. And stage 4A, we find 55% of pelvic nodes and 40% of para-aortic nodes are involved. Next, we come to staging. For staging, we need to remember earlier in 2009, there used to be an older classification. The staging used to be mostly clinical. You are doing a PV examination and you are doing a rectal examination. You are trying to find out the parametrium, whether it's involved or not, whether the rectovaginal septum is free or not. If those are not involved, it's just a growth. According to that, you are staging. So it was a clinical staging in 2009. Whereas in 2018, with the new staging, it has become a clinico-radiopathological staging. We are also taking into account MRI or CCT findings, and we are taking into account biopsy findings in 2018. 2009, stage 1A is when invasive cancer can only be diagnosed by microscopy, okay, with deepest invasion of less than 5 millimeter and largest extension of less than 7. In 2018, this largest extension criteria has gone out of the picture. 1A1 is when it is less than 3 millimeters in depth. 1A2 is when it is 3 to 5 millimeters in depth. 1B onwards, you are able to see the lesions, okay, clinically visible lesions, but they are limited to the cervix. 1B1 and 1B2, less than equal to 4 centimeters, and 1B2 is greater than 4 centimeters. Stage 2 onwards, the cancer has started spreading. 2A is when the lesion has spread beyond the uterus but not to the pelvic wall or to the lower third of the vagina. If it has not involved the parametrium, then it is 2A with parametrial involvement but not up till the pelvic side wall. It's 2B. Okay. So 2A is again subclassified into less than 4 centimeter, greater than 4 centimeter. In 2018 classification, it has become 2A1, A2 and, in 2018 classification, 1B. 1B1 and 1B2 and 2A1 and 2A2 are similar, less than 4 and greater than 4. But in 1B, it is limited to the cervix. In 2A, it has gone beyond the cervix and the uterus. 2B means it's involving the parametrium. At the end, if I have time, I will draw and show you what this means, okay? Stage 3 onwards, it is involving the parametrium in stage 3B up till the pelvic side wall, causing hydronephrosis. And stage 3A, it is involving the lower one-third of the vagina. See, you remember in stage 2, it is spread beyond the uterus but not up till the pelvic side wall and not up till the lower one-third of vagina. Whereas stage 3, if it is involving up to lower one-third, it's 3A, and 3B if it is till the pelvic side wall. Stage 4 is when it has gone beyond the pelvis. The spread has happened beyond the pelvis to distant organs. Adjacent organs like rectum and bladder means stage 4A. Stage 4B means distant organs. Like I said, if it's involved the bone, the liver or the lungs. So in 2018, the staging committee, it was led by Professor Nirja Bhatla of AIIMS, New Delhi, and India, because of its global burden of cervical cancer, is leading the way in both staging as well as management of cervical cancer protocols worldwide. So she along with her committee has changed it. Now it is no longer only clinical staging. It is clinico-radiopathological staging. Lateral extension is removed from stage 1A. So according to the new classification, we just see the depth of invasion in 1A, whether it's less than 3 millimeters or between 3 to 5 millimeters. We don't see whether it's less than 7 millimeters or not in lateral extension. So that has gone out. Stage 1B is no longer two subcategories. Earlier it was less than 4 centimeters, greater than 4 centimeters. Now it is 1B1, B2 and B3. That is less than 2 centimeters, 2 to 4 centimeters and greater than 4 centimeters. Now why this subclassification has been done? There is a fertility sparing technique for cervical cancer less than 2 centimeter which has not spread elsewhere. If a lady does not have any children, we tend to just excise the cervix with tumor free margins and tend to join the top of the uterus with the vagina. Okay, so that is called a trachelectomy. But it has been shown we can do trachelectomy only for cancers with less than 2 centimeters. More than 2 centimeters, then if we do trachelectomy, the cancer can come back or cancer. So that is the purpose of dividing the earlier 2009 1B1, which was less than 4 centimeters, into less than 2 centimeters, and 1B2 is 2 to 4 centimeters. Another reason for dividing 1B1 into two subgroups, 1B2 and B3, because 1B3 now is the previous 1B2. Are you with me? Yeah? See, if you see the 2009 classification, 1B1 was less than 4, 1B2 was greater than 4. In 2018, this has become 1B3, and this 1B1 is subdivided into new 1B1 and 1B2. 1B1 is now less than 2, and 2 to 4 is 1B2. Okay. So two reasons of making this division. One is that trachelectomy we can do only for less than 2 centimeters, and also radical hysterectomy. Previously we used to do laparoscopy, robotic, open, everything, but it has been shown by the LAC trial, LACC trial, that for cancer more than 2 centimeters, if we are doing laparoscopy, then the chance of disease recurrence is more as compared to open surgery. Okay, so for less than 2 centimeters, we can still do laparoscopic radical hysterectomy, but more than 2 centimeters, 1B2 onwards, we have to do a open radical hysterectomy. Okay, so that is the reason of dividing the earlier 1B1 into new 1B1 and 1B2. Stage 2 has remained the same. Stage 3, 3A and 3B are same. There is a new subclassification of stage 3C, lymph nodes. This was not there in 2009 classification. Okay, there was only lower third of vagina and extension up to pelvic side wall. These two are still 3A and 3B, but 3C has come. If pelvic nodes only are involved, then 3C1. If paraotic nodes are involved, then 3C2. And you will get to know about this only by CT scan. That is why it is a clinico-radiological. And 3C1, if we know by CT scan, then it is known as 3C1R or 3C2R if paraotic nodes are involved. In CT scan, we see that short axis of the nodes is more than 1 centimeter, then it's a suspicious node. Whereas if for some reason by ultrasound guided biopsy or by a laparoscopic biopsy, if we have already sampled these big nodes and they come back as positive, then it's known as 3C1P or 3C2P. So that is why a clinico-radio-pathological staging. Stage 4 remains the same. Okay. Adjacent organs like rectum is involved, bladder is involved means 4A, distant organs means 4B. So this classification, if you have any doubts at the end of the class or later, you can ask me. This might be asked in exam vivas. Okay. So how do you stage the cancers? After the initial symptoms, eliciting a good history, examining the patients, you have to do a CBC to rule out anemia, blood sugar to rule out diabetes, urea creatinine to check renal function. See, if it's stage 3 cancer, if it is involved the pelvic side wall, it tends to compress upon the ureters and cause hydroureter and hydronephrosis. In fact, the commonest cause of women dying from cervical cancer is uremia. Okay. So, urea and creatinine, if it is high, if the woman complains of pelvic pain, okay, and hematuria, blood is coming in the urine, then that means you are probably looking at an advanced cancer, stage 3 or stage 4 cancer. Liver function, you have to check urine analysis. If bladder infiltration is there, you will find that blood is there in the urine. Cystoscopy, that is, you put a probe inside the bladder to check for bladder mucosal involvement. If involvement is there and you take a biopsy, it comes back as positive, then it's stage 4A cancer. Proctosigmoidoscopy to rule out rectal infiltration. If it's there, it's stage 4A. Chest radiograph, IVP or intravenous pyelogram. If it's stage 3B, if it is involved the pelvic side wall, if there is hydroureter, you can find it by IVP. CT and MRI, these are the two most important investigations. When a lady comes to you with cervical cancer, you first take a biopsy. Of course, you take a biopsy. When it comes back as biopsy positive, say a squamous cell cancer, the next two investigations you have to do is a MRI. Why an MRI? MRI is important because it gives accurate information about the size of the cancer, the degree of the stromal invasion, how much it's invading inside. As you know, less than 3 millimeters means stage 1A1, 3 to 5 millimeters stage 1A2. Okay, size, if it's a clinically visible lesion limited to the cervix, less than 4 centimeters, less than 2 centimeters, 1B1, 2 to 3 centimeters means 1B2, 5 centimeters but not involving elsewhere, 1B3. Okay, parametrium if it is involved but not going up to the pelvic side wall, then stage 2B. Alright, if it says in the MRI the cancer is 5 centimeters involving the upper 1/3 of the vagina but not the parametrium, stage 2A. Okay, lymph node status is better evaluated by CT scan. So CT scan is useful to give you an idea of the distant metastasis. What are the organs which are involved far away? Whereas for the local spread, how the cancer is behaving, how much it is invaded into the tissues, for that MRI is best. So ideally, when we come across a diagnosis of cervical cancer, we have to do an MRI pelvis or if possible an entire MRI abdomen and a CT scan of the chest and the abdomen, because chest metastasis can be there. If it has gone to the lung, means stage 4B. Okay. Ask me any questions if you have doubts. It's quite a big topic and there are quite a few things I have had to cram here today in one class. But if you go back when you read or if you have read already, you will get the drift. So how do you treat these patients with cervical cancer? Stage 1A1, less than 3 millimeters. You have taken a biopsy. It comes back as cervical cancer. And when you take a biopsy, even after a punch biopsy, sometimes you have to take a bigger biopsy known as a cold knife biopsy. It looks like this. Okay, on speculum you are able to see the cervix. You have to excise like a cone. Okay, because this will give you an idea. Suppose the cancer is here, it has gone up till here. That's the depth of infiltration. And with a cone biopsy only, you will get to know whether there is lymphovascular space invasion. So LVSI is always a pathological diagnosis. It is not a radiological diagnosis, it is not a clinical diagnosis. I often come across reports in ultrasound, in CT, MRI saying LVSI is present. It's utter nonsense. It is not possible to comment upon that other than pathological diagnosis. So if there is no lymphovascular space invasion and it's just a stage 1A1 cancer, then we have options and it's surgical options. Surgical options can be divided into whether you are sparing the fertility or whether you are not sparing the fertility. If the lady has completed her family, you can go for a simple hysterectomy if childbearing is complete. Whereas if she has not completed childbearing, you can do a therapeutic conization on a knife cone, like I showed you in the figure. Or you can do a simple trachelectomy. I'll show you a diagram of trachelectomy. This is what a trachelectomy looks like. This is a uterus, you excise this portion, okay, and you join this top portion to the bottom portion. This is a fertility sparing option for the locally advanced, stage 1A2 onwards or stage 1A1 with lymphovascular space invasion. You have to ensure you give a circular stitch in here. Otherwise, when you join this portion to this portion, this becomes very patulous. It can lead to cervical incompetence. The pregnancies do not hold. So you have to put a cervical stitch and then join. Trachelectomy can be of two types. It can be simple, where you only excise this part. Whereas if you are taking these blood vessels and tissues in the side, then it's known as a radical trachelectomy. So simple trachelectomy is a fertility sparing option or a simple conization for stage 1A1. For stage 1A2, ignore this horizontal spread because it's no longer in the classification. 3 to 5 millimeter cancer, you can do a simple hysterectomy or a simple trachelectomy. Lymph nodes, not that important. You'll remember from the slide, stage 1A2, less than 5% of pelvic nodes are involved and paraortic 0%. Okay. So 1A2 also, you can ignore lymph nodes or at best you can just remove the sentinel lymph node. If it is involving the lymphovascular space, that means the chance of lymph node involvement is higher, around 6.5%. In that case, you have to do a modified radical hysterectomy. Hysterectomy you all have seen in the OTs. This is a picture. In hysterectomy, normal simple hysterectomy, you cut in here, the infundibulopelvic ligament. And you just remove this uterus, cervix and the ovaries. In radical hysterectomy, you have to excise this much farther away. Round ligaments, you have to excise much farther away. See, this is a round ligament here. In simple hysterectomy, you cut it here. In IP, you cut it here. In radical hysterectomy, you cut it near the origin. Okay. If it's a radical hysterectomy, which is a type 2 or modified radical hysterectomy, then you cut it at the junction where the uterine artery is crossing it. Okay. So that's around here. Whereas if you are cutting it right at the origin, you are getting a lot of parametrium, then it's a type 3 radical hysterectomy. So stage 1A1 and 1A2 with LVSI, if you are not preserving the fertility, you do a type 2 modified radical hysterectomy. If fertility needs to be preserved, then a radical trachelectomy. And you have to remove the lymph nodes in this case, pelvic lymph nodes. If it is stage 1B, that is a visible cancer, okay, and it's less than 2 or greater than 2 centimeters, then you have to see the lymph node involvement can be much higher. You have to do a type 3 radical hysterectomy. Okay, that means the parametrium you have to get from the origin. The uterine artery originates from the which artery? What is the origin of uterine artery? Yes. Okay, in which division? Anterior or posterior? Huh? Anterior division. What are the three branches of the posterior division of internal iliac? This is a homework, okay? I will ask you in clinics next. There are 3 branches, you need to remember. So, internal iliac, you have to cut from the origin, from the anterior division of the internal iliac. That's the radical hysterectomy. Yes. So, next day you tell me, you read up and you tell, because that is a very important question. Also anterior division, which is the first branch, which is last branch, terminal branches, everything will be asked. So stage 1B1 and 1B2 radical hysterectomy with pelvic lymphadenectomy. Stage 2A1 also you can do a radical hysterectomy, pelvic lymphadenectomy, type 3 radical hysterectomy. But stage 1B3, 2A2 and the rest 2B to stage 4, you have to go for chemoradiation. Okay, that is what is depicted here. 2B to stage 4B is chemoradiation. But in 1B and 2A also, if some of you are more interested, not all of 1B and 2A, you can do surgery. 1B1, 1B2, that is less than 4 centimeters, you can do surgery. Or 2A1, which is less than 4 centimeters, you can operate. 1B3 and 2A2, which is more than 4 centimeters, also you have to go for primary chemoradiation. You do not have fertility sparing options here, that much, okay. Maybe up till stage 1B1, as I said, less than 2 centimeters, you can go for radical trachelectomy and pelvic lymphadenectomy. So up till stage 1B1, you can consider fertility sparing, not beyond that. less than 2 centimeters tumor, but no lymph nodal involvement, no distal involvement. So this is just reiterating stage 1A1, you can do a conization, okay. And 1A2 and 1B1 or extensive lymphovascular, you have to do a modified radical hysterectomy with pelvic lymphadenectomy. If you have to consider a fertility sparing in this stage, you have to do a radical trachelectomy. Whereas stage 1A1, you can just do a conization as a fertility sparing option. If the lady has completed her family, you can just go on and do a simple hysterectomy. Extrafacial hysterectomy is another name for simple hysterectomy. Simple hysterectomy, what happens is that you may have seen in the OT, we tend to take a pusher and slide the bladder down like this. So when we do an extrafacial hysterectomy, the steps are the same, but we tend to retain a bit of the fascia around the uterus. We do not push it down because the fascia needs to go out with that. Okay. So stage 1A, if we are fertility sparing, then it's a cold knife, which we do. Stage 1B1 and 2A1, radical surgery we can do. If stage 1B1 up till 1B1, we can spare fertility. We can do a radical trachelectomy. For the others, we need to do radical hysterectomy. 1B2 and stage 1B3 and stage 2A2 and 2B stage 3, stage 4, for all of them we tend to give chemoradiation. Okay. This is chemotherapy and radiotherapy together. So what are the pros and cons? When you are able to do the surgery like up till stage 1B2 or stage 2A1, then the advantage is that you can preserve the ovarian function. With radiation, ovaries tend to get damaged until and unless you transpose the ovaries out of the radiation field. And second thing is that with surgery, to know more about the disease spread, surgical staging, ovarian transposition and retention of a normal functional and pliable vagina. Whereas with chemoradiation, permanent ovarian failure can happen, vagina may become fibrosed and shortened, bowel might be involved with radiation, it can lead to bowel colitis, bladder might be involved, it can lead to cystitis, there can be fistula formation with chemoradiation. Surgery, the cons are surgical morbidity, risk of general anesthesia, risk of bleeding, possibility of long-term bowel and bladder problems. Even after surgery, we can have complications like fistula. With chemoradiation, the pros are that it avoids risk of surgical morbidity, blood transfusion, allows for outpatient treatment. So what are the contraindications of radiotherapy? This is often frequently asked in postgraduate and super specialty exams. Associated pelvic inflammatory disease, there is florid PID, you cannot give radiotherapy. Uncontrolled diabetes, inflammatory bowel disease. Radiotherapy has its own late side effects of causing colitis to the bowel. Somebody with IBD, it's not an absolute contraindication, it's a relative contraindication. If the kidney is in the pelvis and you are giving an external beam radiation to the pelvic field, then the kidneys might get affected. If there is a large myoma or the prolapse, the uterus is lying outside, you cannot irradiate the pelvis. If there is an adnexal mass, in these situations, or a genital fistula, this is a very important question. A stage 4B lady, otherwise stage 4 we tend to give chemoradiation, but has already developed a malignant fistula, we cannot give radiotherapy. We have to try and treat the fistula, maybe do a palliative surgery, and then we can consider radiation. Or young women who are trying to preserve the ovarian function. Again, this is a relative contraindication. If by surgery you can transpose the ovaries out of the field, then you can give. Somebody who has vaginal stenosis or cases with adenocarcinoma and adenosquamous, it's a relative contraindication. Because adenosquamous and adenocarcinoma are not radiosensitive. Squamous cell cancers are still radiosensitive, whereas these are radioresistant cancers. Radiotherapy does not work well. So radical hysterectomy, I already told you. Normally, in simple hysterectomy, we just remove this part. Radical hysterectomy, we have to go and take the parametrium. For modified radical, we take up till here, and for absolute radical type 3 hysterectomy, we go up till here. Okay. So there are two classifications of radical hysterectomy. The earlier one was by Piver and Smith. Extrafacial or simple hysterectomy is type 1. Type 2 modified radical, where we remove the medial 50% of cardinal and uterosacral ligaments along with the uterus and cervix. And the uterine vessels are divided medial to the ureter, where the uterine vessels and ureters are crossing. For radical hysterectomy, we are dividing the uterine vessels from their origin from the internal iliac. Okay. And all the other ligaments, the cardinal ligaments, the uterosacral ligaments are divided in the pelvic side wall. Type 4 is where, type 4 and type 5 are very radical surgeries, you may not be asked. Okay, there we tend to even sacrifice sometimes the internal iliac artery, okay, the superior vesical artery and all. Now a new classification is known as Curly-Modo classification, the ABCD classification. Type A is the earlier type 1, type B is the earlier type 2 or modified radical. Type B is when the uterines are being cut near the ureters, when they are crossing the ureters. But when the lateral paracervical lymph nodes are not removed, it's type B1. Whereas paracervical lymph nodes are removed means type B2. Type C1 involves the excision, the uterosacral ligaments up till the level of the rectum. And the uterine vessels are divided at its origin. But this is autonomic nerve plexus is preserved. Just a nerve sparing radical hysterectomy is type C1. Whereas if the nerves are not spared, then it's type C2. What happens is that when we are dividing the uterines near the origin, okay, or we are dividing the uterosacrals right from the sacral promontory or the cardinal ligaments from the promontory, we can sometimes damage the pelvic splanchnic nerves. There is a surgical technique in which we can avoid this. That's the nerve sparing radical hysterectomy. So if you are able to do nerve sparing, it's type C1. If you are not able to spare the nerves, it's type C2. Exenteration and others come across type D. Okay. So when we are doing a radical hysterectomy, we need to do pelvic spaces. So this uterus is here. This is the psoas muscle. There is one very thin nerve running here. It's called known as the genitofemoral nerve. Then these are the external iliac arteries. This is wrongly mentioned. This is the internal iliac artery. The ureter is here and posterior surface is here. So there is two pelvic spaces which are developed, pararectal and paravesical space. External iliac arteries. This is divided by the uterine artery, which is a branch from the internal iliac. Divides it into the anteriorly the paravesical space and the pararectal space. Developing these spaces are important because not only you are removing the uterus here, you are removing this tissue also here, the parametrium. That is why it is known as a radical hysterectomy. If you are dividing from here, it's a simple hysterectomy. You are taking this tissue, this behind everything, that's a radical hysterectomy. That is why you need to divide these and develop these spaces, paravesical and pararectal spaces. Paravesical space is bounded anteriorly by the bladder here, laterally by the psoas muscle and the external iliac vessels. Medially, there is the ureter which is running here, and posteriorly by the uterine vessels and the cardinal ligaments. Whereas pararectal space, anteriorly there is the cardinal ligament, medially again there is the ureter, this is the ureter running here. Laterally there are the external iliac vessels and posteriorly this is the sacral promontory. Okay. When we are doing pelvic lymphadenectomy, we have to remove this. I have done a few of these surgeries here in Shantiniketan. Few of you may know. From the external iliac vessels, these are not visible like this. You remove all the nodes here. From here, internal iliac. This is the obturator fossa. This is the obturator nerve, this white structure. So when you are removing the obturator node, this nerve is visible. This is a radical trachelectomy as I mentioned earlier. What are the candidates? You can do only for lesion which is less than 2 centimeters. 1A1 with LVSI or 1A2 and 1B1. 1B2 onwards you cannot do trachelectomy. You cannot preserve the fertility even if you want to. Okay. So less than 2 centimeters, there should not be any lymph node involvement, no endocervical involvement. The cervix should have good length. The patient should want a future fertility. You find a young patient, you say, okay, let's go and do a radical trachelectomy. But the patient says, I don't want any children anyways. I want to be alive. Then you do a radical hysterectomy, not a radical trachelectomy. And there should not be any evidence of fertility being impaired. If somebody's fertility is already impaired, then you are doing such a difficult surgery, and then you find that the ovaries are not working. There's no point of doing that then. So I have already mentioned you have to do a cervical stitch also when you're doing a trachelectomy. Otherwise, there can be cervical incompetence. Cervical hysterectomy. For squamous cell cancers, you can retain the ovaries if you want for younger patients. Pelvic exenteration you do only for stage 4 disease or central pelvic recurrence on PET CT without metastasis if there is no pelvic sidewall disease. Exenteration means you not only do a radical hysterectomy, you also remove structures in front and behind. See, if the stage 4A bladder is involved, you remove the bladder as well as the uterus and you create a new bladder from the ileum, which is known as the ileal conduit. Whereas posterior exenteration means you do a radical hysterectomy and you remove the rectum as well. Okay, and you do a colostomy. Complete means you remove bladder, uterus and rectum, everything. This is only for stage 4 disease, okay. So complications after these radical surgeries, there can be fistulas. Fistulas can be there both after radiation, after surgery. After surgery, it's 1%. After radiation, it can be 4 to 5%. There can be cystitis or pyelonephritis, lymphocystal lymphedema, or neuropathies. Femoral obturator nerves might be involved. After surgery, sometimes we have to go and give post-op adjuvant therapy. Post-op chemoradiation we give when the lymph nodes come back as positive, or if there is parametrium which is involved, or if the margins are involved. For the other criteria, we tend to give only radiation, not chemo. Cervical cancer is quite common in pregnancy. We cannot use a CT scan in pregnancy. We tend to use an MRI. And if it's early stage, stage 1 to 2, close to viability, we wait for a few weeks if patient is willing, and then we can do a cesarean section as soon as patient reaches 32 weeks or 34 weeks. Okay. Cesarean section followed by radical hysterectomy and lymphadenectomy. Incision may be modified, a midline vertical incision will be given. If the fetus is non-viable, then a radical hysterectomy with the baby in situ. If it's a lady with cervical cancer stage 1B1, okay, but only at 12 weeks, then there is no point because her life is first paramount. You have to then tell her that we cannot continue this pregnancy, we can do a radical hysterectomy with the baby in there. Post-treatment follow-up, you have to do clinical examination of supraclavicular and inguinal nodes. If these are positive, then stage 4. For the first couple of years, you do every 3 to 4 years, 3 to 4 months follow-up. For the next 2 years, you do every 6 months. 5 years onwards, it's annually once. Chest X-ray, CT scan, these are needed. What are the non-surgical modalities? It's radiotherapy and chemotherapy. Radiotherapy you can give from a distance. It's known as external beam radiotherapy. If you are putting tandems and ovoids within the vagina to treat the cervix locally, it's known as brachytherapy. Okay. So radiotherapy, teletherapy, telecobalt, linear accelerators, gamma knife is used. There is low dose and high dose and simulators. This is what a radiotherapy machine looks like. Intracavitary brachytherapy, we can use low dose with cesium-137 or iridium high dose. Half-life is 74 hours. We can preload or afterload. Now these two are asked importantly in exam, point A and point B. If we give at point A, then there is good amount of radiation. This is for stages, stage 1B3, stage 2A2, 2B, 3, 4. Okay, you have to give radiation along with chemotherapy. Radiation you have to give at point A. The point 2 cm superior to external os and 2 cm lateral to cervical canal. And point B is 3 cm lateral to point A. Point A. Okay, this is point A. This is a mistake. So we tend to target these 2 points when we are giving radiotherapy so that there is good amount of external beam radiation given. And for brachytherapy, it is important these three techniques: Paris, Manchester, and Stockholm. For brachytherapy, as I said, we put these tandems and ovoids within the vagina so that the radiation is given locally. Okay, so it can be first A denotes Stockholm technique. So I will start with Paris technique. This B, where there is one application for continuous 5 days. There is a tandem, one tandem, and ovoid. These are the ovoids, the round structures, and this is the tandem. Manchester technique means we apply each 72 hours for 7 days. 2 applications. 3 applications is with Stockholm. PMS. You can remember 1, 2, 3 applications. Okay, and 24 hours each weekly interval is Stockholm. So indications, you can give radiotherapy for all stages, but for operable cancers it's better to go for first surgery. Mostly it's indicated for 1B3. So this is based on old classification, okay. Bulky tumors more than 4 centimeters. Now this is 1B3 or stage 2B, 2A, 3B. You tend to give both external beam as well as intracavitary brachytherapy, and you give cisplatin also. Cisplatin is given because it potentiates the effect of radiation. 40 milligrams per meter square it is given dose. And stage 4A also you can give both. So stage 1B2 onwards is written, it's the earlier classification. Now till 1B2 you can do surgery. 1B3 onwards you can give radiation. 2A1 you can operate less than 4 centimeters, greater than 4 centimeter. 2A2, 2B, stage 3, stage 4 you can give chemoradiation. Chemotherapy, there are different ways. One which is used is cisplatin and 5-fluorouracil are the most important chemotherapy drugs used. 40 milligram per meter square weekly for 5 courses. You can give cytotoxic, it's additive with radiotherapy. And it tends to provide good response for stage 2B, stage 3 and 4 cancers. But there is toxicity. Sometimes for bulky tumors, earlier we used to give neoadjuvant. First chemotherapy, reduce the size of the tumors and then operate. But recent evidence has shown that for bulky tumors, it's better to go for radiation and chemo as primary. Because if you operate, it margins come back as positive or the lymph nodes come back as positive. Then you have to again give chemo and radiation. That dual modality means fistulas and everything increase. So it's better to go for a single modality and go for chemo radiation in the beginning itself. Palliative is for only stage 4. So this is the survival. See, for stage 1A, 1B, it's very good survival rates of 5 years. Stage 1, it's 90 to 95%. Whereas for stage 2B, it's 60%, stage 3, 30 to 50, stage 4, 10 to 20%. What are the sequelae of radiotherapy? There can be abdominal cramps, diarrhea, bladder symptoms like cystitis, hematuria frequency, erythema, and radiation vaginitis. The vagina tends to become very narrowed down. Late sequelae, there can be cystitis, fistulas, vaginal stenosis, anal incontinence, femoral neck fractures, and nerves are can be involved. Chemotherapy complications are mucositis, nausea, diarrhea, vomiting, phlebitis, myelosuppression, alopecia, cardio, renal toxicity, neuropathy, sterility, cystitis. For palliative treatment for bleeding, we tend to give palliative radiotherapy. If the patient is stage 4 but bleeding, okay, stage 4B, you cannot really start and give a chemoradiation because sometimes urea creatinine is very raised or there is florid infection. Then to stop the bleeding, you can give palliative radiotherapy or you can give a vaginal pack with Monsell solution, ferric subsulfate. This same solution is used if in OPD you have taken a biopsy and if it is bleeding, alright, you can use it. Looks bluish in color. For pain, you can use all these radiation, NSAIDs, gradually go up the pain ladder. Opioids, benzodiazepines, persistent nausea and vomiting, you have to give ondansetron, palonosetron, 5-HT receptor antagonists. Neuropathic pain, you can use carbamazepine, and hospice support needs to be there. So this is an important slide. What are the causes of death in cancer cervix? You will know in ovarian cancer, the cause of death is bowel obstruction. Whereas in CA cervix, the commonest cause is uremia due to ureteric obstruction and parametrial involvement, hydroureter hydronephrosis. Patient goes into renal failure and she dies. The only way of preventing this is sometimes we can do a percutaneous nephrostomy. Okay, we can stent the ureters if possible. Otherwise, we do a PCN, urea creatinine comes back to normal, and then we give chemoradiation. Fetal vaginal bleeding, hemorrhage is the second most common cause. Sepsis, cancer, cachexia, and severe weight loss, malnutrition, and metastasis to lung, lymph nodes, bone, and abdominal cavity. These five are the causes of death in CA cervix.